The newest kid on the block, the newest drug that's been approved and shown to be clinically useful is bempedoic acid, brand name Lexletol. And this is a prodrug which is inactive until it gets into the liver, where it's converted to its active form, and it inhibits an earlier step in liver synthesis. If you, this is a little schematic of the production of cholesterol in the liver. You can see the gray arrow where the statins work, and the green arrow is where bempedoic acid works, an earlier step in the cholesterol synthesis sequence. It's taken orally, which obviously is more appealing to many people than injections. It is not nearly as effective at lowering LDL cholesterol as the 3 injectable drugs. Compared with placebo, it decreases LDL cholesterol about 21%. For those who are fans of the pleiotropic action of statins, it's an interesting side note that bempedoic acid decreases high sensitivity CRP by 26% compared with placebo. There is a fixed dose combination of bempedoic acid with ezetimibe, and that lowers the LDL cholesterol a more impressive 38%. But at the moment, there are no clinical trials of this combination. The CLEAR trial was reported at the last ACC meetings and published a little over a month ago in the New England Journal. A large trial, 14,000 patients who had either known coronary disease or considered very high risk, and who were statin intolerant, who refused to take statins of any sort, or either because of objective or subjective reasons. Mean entry level LDL cholesterol was 139. Similar study endpoints, they followed up for 3.5 years, and the LDL cholesterol, as predicted, was reduced by a mean of 21%, and the primary endpoint was reduced 13%, with an absolute reduction of 1.6%. Very statistically significant. There was no difference in deaths, and the major side effects reported were small increases in symptomatic gout and symptomatic gallstones. So is this in the same league with the injectable drugs? No, it is not, but it is an option for those who will not take a statin, and at this point will not take an injectable drug. Wonderful drugs, lower cholesterol, reduce heart attacks, reduce deaths. Is there a problem? Yes, and the problem is their side effects on the wallet. As you're, I'm sure, well aware, generic statins are now available that are so cheap that most insurers don't even put on a copay. If your patients do have to pay for them, they can probably get them for about $5 a month. The 2 antibody drugs are both in the $6,500 a year range, as is inclisiran. Bempedoic acid, $4,500 a year. So these are not insignificant costs. And it's particularly a concern when you figure that your average coronary patient is frequently taking multiple drugs for other conditions, and really is hurting if they don't get this covered by their insurance. So a side effect for the prescribing doctor is you've got to go through hoops to get their insurance to cover it. And it would be nice if it were easier, but it isn't. Where do the experts say we should use them? These are the published guidelines from several years ago. They will probably be updated, but haven't been. And they basically say that use of these drugs should be considered in people who are at high risk, who are on a maximum tolerated statin plus ezetimibe. And you can look at different groupings, but it's the idea is the same, that people who are not at goal, who are either known to have coronary disease or at high risk of coronary disease, and are either on a statin but not at goal, or simply will not take a statin. What is very encouraging for your injection intolerant patients is there are a number of oral PCSK9 inhibitors that are being studied. There are at least 3 actively being studied that I'm aware of by Merck, Pfizer, and Novo Nordisk. The Merck drug is furthest along and then had a dose finding phase 2 trial reported at the ACC meetings, and it was published in April. And they were patients who, again, had either clinical coronary disease or were very high risk and had LDLs over 70. And they were given 4 different doses of the oral drug, and it worked at all doses. It looked as if there was a plateau somewhere around the 12 milligram per day dose, but wonderful reduction in cholesterol. At this point, no clinical data at all. The drug will be starting a large clinical trial, and I don't expect reports will be out for 2 to 3 years, but again, well tolerated, very effective at lowering cholesterol. All right, to sum up, step 1, you've got a patient in front of you, think globally, think risk. If you have an active patient who doesn't smoke, who has a normal blood pressure, has no unusual family history, and a modestly elevated cholesterol, you need to have an informed discussion of the fact that this may indeed lower their risk of heart attacks if you put them on a drug, but that their absolute benefit is going to be modest. And you'll have patients who say, yeah, I want to have my heart attack risk reduced by 30%, even if it is only from 0.6 to 0.4, and go right ahead. You've got good drugs available. If they say, I hate taking medicines, and how much is this really going to help me, you can assure them that it's not unreasonable to just follow along, do their best with diet, and keep an eye on it. If you're going to treat, you should always start with a low-dose statin. I don't think it matters a whole lot which one you pick. My favorites tend to be the rosuvastatin or atorvastatin, certain psychological effect that you're giving people a low number of milligrams, and so they feel more comfortable with that. But whichever drug you start with, start low. Remember the fact that starting somebody on the lowest effective dose is going to give you 50–60% of the benefit that you'll get from the maximum allowable dose. So avoid complaints, avoid muscle aches, start with a low dose and measure and go up as needed. If people feel well, there's no need to do routine testing of muscle or liver, but if they have any sort of side effects, however non-specific, I would check CK and liver enzymes. If you have significant elevations of liver enzyme or CK, then the statins are not for them. Stop the statin, use an alternative drug. If their problem is primarily muscle aches, their CK is either normal or minimally elevated, I would switch to a different statin or a lower dose. If you've gotten up to 3 or more statins and patients are still not happy, you can switch them to oral bempedoic acid. And if they're still not at goal with that, that's the time to go to a PCSK9 inhibitor. If they are on a statin and they don't reach your mutually agreed upon goal, which would be below 100 as primary prevention, below 70 for secondary prevention. First step is add ezetimibe, 10 milligrams, inexpensive, well-tolerated. If that doesn't get you to goal, then it's time to either add on or switch to a PCSK9 inhibitor. I have done a lot of talking, and I will now open the floor up for questions. The webinar was sponsored by MDforLives, premier healthcare market research firm. Doctors can register, become part of the community, take surveys, participate in quizzes. So the sponsor urges you to sign up. If you would care to ask a question or make a comment, please raise your hand and we'll try to get to all of them. Shoot.
Dr. Hoffer?
Yes.
Thank you so much for an excellent talk. Alison Muffler here from Kingston, Ontario. I like the approach of trying to start, with the lowest effective dose and then escalating. How do you handle patients who have symptoms despite stopping the medication, but they still, strongly believe that statins are causing their myalgias? Because there's a lot of media and press about the statins, unfortunately, that is making it difficult for us to start on patients. How do you handle that in terms of discussion and counseling?
Well, I try to, and now there is really good data saying that a lot of this is nocebo effect. And I tell people my own little anecdote about my own myalgia that I attributed to the statin. And then I go over with them the fact that people have done studies showing that whether the patients were taking a statin or taking the sugar pill, there was an equal amount of muscle aches, and ask them if they're willing to try a lower dose. And if they say, no, I'm convinced this drug did it to me, then I can, with science behind it, say, well, you've been on a fat soluble drug. We're going to switch you to pravastatin, which is water soluble and is less likely to do this. And I would say 2/3 of the time, after 2/3 of the time, they're quite comfortable on pravastatin, having gotten muscle aches on one of the other statins. If they insist, and we've tried that, and we've tried CoQ10, and they still say, this stuff is awful, I ache, then they ache and they're not going to take it, no matter, and there's no point in you saying it's all in your head, because they're going to say that doctor doesn't understand, and they stop the drug. So I would say at that point, that's the time to use one of the alternatives, and hope you can get their insurance to pay for it. Say 4 years ago, 5 years ago, all I had to offer them was Zetia, which was only minimally effective. Now we do have more effective drugs. So, if you've gone the extra mile, sat down with them, tried to work with them, and they insist this drug is awful and I hurt, and all my friends tell me that it hurts, and I read it on Facebook, well, then no matter what you say, they're going to stop. So you may as well work with them and try to find one of the newer agents that they can afford. One thing I didn't touch on because of interests of time, but we have a few minutes, is LP little a. which has now been recognized, I think, convincingly as a risk factor for coronary disease. One reason I didn't mention it is we have no available therapies to lower it. But it is something, if you've got a patient who's got a nasty sounding family history and their basic lipids don't look too bad, I would definitely measure an Lp(a) and give them the one thing we do have available. Start treating their LDL cholesterol. One thing about Lp(a) is it seems to be genetically determined, so you don't need to keep measuring it. Measure it once, and that'll give you all you need to know. So again, if you're on the fence with somebody as to whether they should be on lipid lowering drugs, that's an extra piece of data that you can throw into the mix. Thank you all for being part of the webinar. We hope to see you again. If you want to reach out to me directly, you can email me. It's ehoffer@gmail.com. And thank you for participating.